Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
In the profession of physical therapy, my profession, a lack of gay, lesbian, bisexual, transgender, and queer-specific education has given rise to deficiencies in our cultural competence and our humility. When deficiencies exist in a profession's educational system, as well as its continuing education system, it can create a climate of discrimination and disparity, which ultimately leads to decreased access to health and effective healthcare. Now, in the context of chronic pain, which is what we discuss on this podcast, LGBTQ people are more likely to suffer from a long-term chronic pain condition than heterosexuals. So to begin today's episode, I'd like to share with you a couple of reasons why this community or this population of people experience more pain before we meet our expert guest today. So the first reason is that a larger portion of the LGBTQ plus community lack access to health insurance or actually live in poverty, more so than their heterosexual counterparts. Now, because of this, they're more likely to delay medical care or at times just forego it completely because they can't afford it or they simply just don't have access to quality healthcare. The next are psychosocial issues. We talk about anxiety and depression and the link between anxiety and depression and chronic pain oftentimes on this podcast. We know that the rates of depression and anxiety are higher in the LGBTQ plus community than heterosexual populations. The reason why is because they're more likely to experience injustice, prejudice, social stress, exclusion, hatred, and even violence that can contribute to this increased incidence of depression and anxiety. How about physical activity? Investigations have demonstrated that only 42% of LGBT plus people meet the level of physical activity required for good health compared to 60% of people in the general population. Now, we know that participating in exercise and regular physical activity is a fantastic way to prevent or delay the development of chronic pain. We also know that certain people and institutions still have a negative attitude toward LGBTQ plus people. It's these attitudes that can lead to social isolation by friends, by family, by employers, and even society at large. People who are socially isolated are more likely to develop chronic pain than those who are not. And then there's childhood trauma. We know that childhood trauma primes the nervous system and creates more pain as people move into adulthood. All of you have access to PubMed. If you want to see some very concerning statistics, look at the incidence of child abuse, sexual abuse, and physical assault that exists for LGBTQ plus children and adolescents. And then finally, there's substance use disorder. LGBTQ people have a higher incidence of substance use disorder. Consider for a moment living in a world where you are stigmatized, where you're socially isolated, where you lack access to proper healthcare or don't have any access to healthcare at all, where you've been rejected and now you feel worthless and you have feelings of self-hatred and fear of rejection is really around almost every corner. What happens in that case is that people develop challenging emotions, and to try to mute these emotions so they don't feel emotional pain and they don't feel physical pain, they turn to substances because certain substances provide a sense of euphoria or relief. However, we know that early or long-term use of certain substances, such as opioids, lead to a decreased pain tolerance and an increased sensitivity to pain. At times, living as an LGBTQ person in this society hurts unless you find the proper network and support that accepts who you are and who you want to become. Joining us today are three physical therapists, Dr. Melissa Hofmann, Dr. Chris Condran, and Dr. Karla Bell, who are leading advocacy efforts for the LGBT community within the physical therapy profession. As I mentioned, all three are physical therapists. All three are physical therapy educators, meaning they work in a DPT program. And all three have conducted research in the area of LGBTQ plus disparities within the physical therapy profession. On today's episode, we'll discuss the main issues that impact the LGBTQ plus community when accessing healthcare, as well as advocacy efforts at the level of physical therapy education and the American Physical Therapy Association. Okay, without further ado, let's begin and let's meet Dr. Melissa Hofmann, Dr. Chris Condran, and Dr. Karla Bell. Hey there, Chris, Melissa, and Karla. Welcome to this week's episode of the Healing Pain Podcast. It's an honor to have the three of you here.
Great to be here.
Thanks, Joe.
Thanks for having us.
So it's June. Every year in June, I do an episode, at least one, sometimes two. I do at least one episode on LGBTQ plus issues in physical therapy, but of course that extends to chronic pain and physical health and mental well-being, lots of different overlaps there. Chris, you've been on before. Karla, you've been on before. Melissa, it's your first time here. We welcome you. And I know the three of you collectively, as well as individually, are constantly working on this important topic at the APTA level, the American Physical Therapy Association level, which we appreciate their input and their assistance on this topic. And I know you're all working on it in your respective universities because you all teach DPT programs, and then you all individually have projects, research, really evidence-based research going on that I want to talk to you all about. But I think, look, I've been a PT since I started PT school in 1995. So I've been a PT for a long time. I am a member of this community. I identify as a gay male. So this is an important topic to me, which did not exist in 1995. And I'm not even sure how much of it even exists now. You can all talk to that later. But as a profession, not pointing fingers at any one person or group, but as a profession, we're a tiny bit late in bringing affirmative action or affirmative practice, I should say, in this area to the profession and our colleagues. And, organizations like the American Psychological Association, for example, have had statements and trainings and massive amounts of information. So I guess the question is, why are we a little bit late and what should we be doing? Big question to start off, but I really think that's people who are like me and like us, identify like us, and our peers, our straight peers who support us, want to have the same question answered.
Yeah, great question. I don't know if Mel or Chris, you want to go first, or are you happy for me to go first? So I think, the structure and operation of professional organizations have some limitations, right? With moving, into social justice advocacy realms of health. And you mentioned, APA and, AMA, and you're right. There's a lot of professional organizations that have stepped up a bit in at least, I'm not going to call it performative, but at least public advocacy statements or those kinds of things. And physical therapy professional organizations, you're right, have not. We do need to shift our sails a little bit on our sailboat right now as professional organizations in health, right? Because, now more than ever, the systemic inequities for vulnerable populations, historically traumatized populations and marginalized populations, they're having an immeasurable impact, right, on the health and well-being of people. And so any health professional organization in their mission and values and core values has an obligation to stand up for equity and health equity. And today, that looks very different than it used to look. And dare I say, of paramount concern is the political determinants of health for these communities right now. In 2021 and 2022, it has been historical. And when I talk about the political determinants of health, that means how politics legislate lives of people. And their legislation implemented into public policy has impacts all the way down with these structural inequities that exist for these communities. And so I'll let my other peers talk as well.
I think that the profession at large is moving in the right direction. I agree with Karla in her sentiment that, and Joe, your sentiment that we are late to the game, right? But I think if you look at the historical context of our profession, Gail Jensen put out a great editorial recently, 2022, for PTJ, where she was commenting on her own personal experience and perspectives about Ross et al.'s paper that was published December 2021. And that was looking at the experiences of LGBTQ practitioners or people in academia and what their experience was as an LGBTQ person within those fields, and really going back in time. And I think that the editorial was, to the effect of time will tell or something like that, right? So really looking back at, the discrimination and even the not so much outright policy, but it just really wasn't talked about, right? It was, there weren't DEI initiatives that were happening at that time. I agree with Karla. I think that is really fostered and facilitated by current social politics, right? And where society has come to in the last, 20 or 30 years per se. Everybody, if you get a chance, definitely read that editorial. It's a great read. Gail Jensen is one of the best educational researchers out there and has quite a bit of experience and really shared her personal journey in that realm. I kind of want to go into a little bit of talking about our professional organizations. And I will say that our professional organization has demonstrated advocacy in context through their commitment outlined in their policies to be accepting of all communities, regardless of race, gender, and sexual identity, disability, et cetera. But the most powerful advocacy is to not only say that you support something, but to demonstrate through action that you do. So it's more powerful to have a national or state organization provide support against specific policy that is discriminatory, especially when it involves a community that is part of their own organization. So what would this potentially look like? Maybe public support behind policy initiatives that are set forth by state delegations, for instance, to advocate for the LGBTQ plus communities, public display of discontent or disapproval of policy that overtly discriminates such communities, and maybe even public collaboration with organizations for events that support the community. But I think the key word here is being more public.
Thanks, Mel and Karla. I'm just going to kind of build off of that a little bit. Again, I kind of see this more as a looking inward at our profession as a whole. When we look at examples of professions like social work or psych or even medicine, we see professions that have created clinical practice guidelines for these populations that specifically look at identifying the disparities that are happening and addressing them specifically through educating our students and our clinicians in continuing education and creating those clinical practice guidelines that would drive practice that would be high quality, inclusive practice rather than practice that is willy-nilly and not actually driven by the evidence. We as clinicians have a responsibility to deliver evidence-based practice, and in physical therapy realm, there really isn't a lot of evidence-based practice going on, particularly when addressing the specific needs of trans people. We know from recent studies that students are really only getting around an hour to potentially at the greatest 3 hours on this topic in most academic programs, particularly in doctoral programs and for physical therapy. And so that to me is alarming, right? We see, for example, we are in a lot of states, physical therapists, direct access clinicians. And so we treat patients without a referral from a physician. If we don't create an inclusive environment that allows for patients to feel comfortable disclosing their medical status, whether it's what types of medications they're on, what types of procedures they've had, we could actually harm them with our treatment. And so when it falls back on trans folks in particular, most clinicians have no idea what gender affirming care looks like, whether it's hormone blockers that are being received by someone or gender affirming hormone therapy. And some gender affirming hormone therapy carries specific health risks or issues that can potentially be lifelong that we should be screening for before providing care. And so that's why clinical practice guidelines would be essential to creating and establishing a process for treating these patients in an appropriate way. And so for me, it kind of comes back to what are we doing at the professional level. In addition to the advocacy, we need to acknowledge that LGBTQ people have a specific set of needs that are not being met because our clinicians are not being educated, whether it's in academic settings or in continuing ed. And so kind of following back to that funnel of creating clinical practice guidelines would address both and those situations, along with addressing the specific health disparities that are happening with access and quality of care, and with providing top level quality of care for these patients.
Excellent beginning to all of you. So Chris, I want to just stay with you for a minute and I want to go to Karla we're going to speak with Chris first. I want to go to Karla because Karla said something that made me perk up a little bit. So Chris, clinical practice guidelines, we have them for things like chronic low back pain and osteoarthritis and every condition that we see as physical therapists. Is there a clinical practice guideline in the works for affirmative practice in this area? Has anyone started to pursue that? What's the feedback been about that? Where are we going with that?
So in the physical therapy realm, no. Like I mentioned, other professions have clinical practice guidelines for LGBTQ plus folks, but we do not have them here in physical therapy. This is something that when I was on your podcast 3 years ago now, I think, when I first started my transition, this was something I was talking about and bringing into the spotlight then, and it is still kind of not been mentioned much. When I attended the clinical practice guidelines workshop, I was addressed in a way that said, basically, there isn't enough evidence for us to have clinical practice guidelines in physical therapy for this. Mm-hmm. This was, like 3 years ago. In my opinion now, over the last 5 years, there's been a huge surge in the amount of evidence that we have, particularly around the trans community and gender affirmation, whether it's gender affirmation surgeries or gender affirmation hormone therapy. We have so much more information that really, at this point, I feel we really should have these, particularly from a differential diagnosis standpoint and from a direct access care standpoint, because we could potentially be missing lots and lots of things, from nerve damage, from laying on the table for long periods of time, from surgery. Therapists aren't thinking about those things because they've never had the experience of being trans. They haven't had those experiences of being on hormone therapy or gender affirmation surgeries. And so they may not even had a friend, an acquaintance who's had those experiences. And so really it's just the ignorance piece that's kind of globally given us this space where people don't know about these things, and they're not thinking that way because they haven't had those experiences or shared those experiences with a loved one or a friend or an acquaintance. And so having gone through some of them myself and having a lot of acquaintances and friends it has changed my perspective. And I am a direct access licensed therapist, and I work in outpatient orthopedic settings. And so it has really, really shaped how I see why these clinical practice guidelines are so important and why we should have them, and trying to drive the change to create them.
My question, when you say, so you're in this atmosphere and you're interacting with your peers in obviously a public arena, so to speak, and someone says to you, there's not enough evidence. Now, okay, when I sit here and I all of you know the evidence way more than I do. And I would say, sure, we need more LGBTQ plus evidence in physical therapy specifically. Yes. And as licensed health professionals, why can't we pull from the evidence that does exist in the other professions, medicine, psychology, social work, et cetera? Why can't we pull from that and use that? For example, the therapeutic alliance is one of the most important factors in any type of condition that we see as health professionals. A lot of the affirmative guidelines that the American Psychological Association put out for LGBT practice are really along those lines. How do you foster a therapeutic alliance with the population that you may not have ever had any experience with, and that's okay. But why can't we start to pull from that? And if we at least had that, so to speak, where we know how to treat people like human beings that deserve care, why can't we start with that? And then, yes, we can figure out, okay, if you're treating, then we get into the low back pain for this population and physical therapy, very, very specific things. But that doesn't resonate with me anymore.
Yeah, I think you bring an interesting point to that. It's the recognition of this being an issue. And I think that is a place where our profession has been in denial for a long time, that we can just treat everyone the same, right? That is part of what we've done in our research. All three of us are in research groups together. I can tell you, I just ran a pilot study as part of my dissertation. I had 130 respondents, and I had almost unanimous support for creation of clinical practice guidelines and for it to be and for this content to be CAPD accredited in DPT programs.
Well, that's another topic right there, a sensitive one you touched on. So I'm assuming there's nothing in the CAPD accreditation guidelines that mention LGBTQ plus individuals in care. That's a problem.
There's not. It's my understanding those are being updated. I don't have any idea what those look like. I'm told that DEI is heavily being integrated, but again, I don't know what that means.
Right. And those guidelines aren't updated every year. It's every 5 years or something like that? Does that sound about right?
Yeah. And one of the biggest issues with CAPD at this point is individuals can't publicly identify as they truly identify within the CAPD framework. So if you go to like PT-CAS, one of the big challenges for folks, for a lot of academic institutions, as far as admissions go, is they really don't know who identifies as what, because there's no options within the CAPD framework or the PT-CAS network for them to identify as such. So, it makes it really challenging when you're trying to diversify your student body and you're not getting that important information from PT-CAS, which is essentially sponsored by CAPD.
And that same experience is going on in HR departments across academia as well. They're not collecting any gender-related information from an application standpoint, other than male and female. So if you are non-binary, there is no place for you to put your true identity in. So academic programs have no idea who they're recruiting, whether or not it's a diverse hire or not, unless you're known, to them outside of that space.
Yeah, it's interesting because I was reading some information recently on Generation Z, which is the upcoming generation, and how really they're much more diverse in this area, and they identify much differently than probably all of us did because we really didn't have this, right? Yeah. We didn't have this language. We didn't have these constructs to help explain what our lived experience is like for people. But as you look at these younger generations, like they're already leading, even though we don't necessarily have the policies in place either on the APTA level, state level, or the legislative level, obviously politics. So they're leading, but they're starting to come into PT school already with this vernacular, and we're not necessarily able to meet them, which is just interesting for us to think about. Karla, I want to come back to you because you mentioned the word political determinants, which is probably somewhat of a new word on, this podcast. We heard about personal determinants of health. We've heard about social determinants of health. When you mention political determinants, obviously you're talking about jurisdictional and legislative changes, which are important. The question in my mind comes, as a licensed healthcare professional, if your state were to pass anti-LGBTQ legislation, that you see could potentially impact the health of individuals and communities and populations, do we have a responsibility to become active in that and raise our voice and say, yes, this could potentially impact not only the health of populations, but we know that when health is impacted in the United States of America, finances and economics are also impacted, right? So that's my question. When you talk about political determinants, where do we really, how do we where do we go with that as a profession?
That's a great question. And I mean, the bottom line, it's actually pretty simple when you break it down to health equity, right? Our core values, right? Our mission, state, and even our public policy priorities actually this year revolve around advocacy efforts for social determinants of health and health equity. And so when we look at it through that lens, the political determinants of health are front and center for these communities for the past 2 years, at least, if not forever, but especially these past 2 years. And so I would say we as professionals, health professionals, have an absolute obligation to understand what is going on for communities related to public policy efforts and legislation, because the implications then are numerous. I mean, I can think of a number of examples right now. There are many states now that gender affirming care is illegal. And some of them have stipulations related to health professionals providing care. And some of them have mandatory reporting parts to it too.
Can you give us an example of what that looks like?
As a health professional, if we have a minor that comes into us for physical therapy, okay, and they disclose their identity to us, there is some legislation out there to say we have to tell the parent. Now, that is completely unsafe, and we have no obligation under HIPAA or anything to provide that identity to the parent or guardian, only what is the plan of care and related to why they're coming to us and their health needs.
And that's not just specific for physical therapy. That could be any licensed health
provider. That could be any health professional.
Right. So if an individual, if an adolescent is in therapy with a psychologist or a mental health professional, and they're working through their identity, so to speak, that professional is supposed to then finish the session up and disclose to the parent what's happening behind closed doors in a private session.
Correct. And I mean, I don't have time to go into the horrific statistics related to the safety of our youth,
right?
But 40% of homeless youth are LGBTQ plus, and that statistic has not changed for decades.
Yeah, and the suicide rate in that
absolute
population.
And so we are endangering. Yeah. These laws are actually endangering, but as back to your point, as health professionals, you know, again, it goes back to health equity and what does that look like? And it goes back to cultural compatibility and what does that look like? And we are not doing our job as physical therapists with these communities in those realms.
Yeah, I agree with Karla. If our PT Proud organization or our committee, our advocacy committee is recently, there's so much policy out there that is discriminatory against all of our communities that it's, you can't just pick one, right? There's probably over 200 bills right now that are out there, and when you look, it's more than 200. As I said, more than 200 bills, but it's incredible. And when you look in the way that PT Proud in our advocacy committee is organizing this is really looking at what are our core values as a profession? What are our ethics? And what do these policies look like in coordination with our core values and ethics? And just to give you a few examples, when we think about accountability is a huge one, right, for the profession. And there is not ordinance in place for non-discrimination within religious organizations. Discrimination against employing LGBTQ plus persons. It's still legal in some of those spaces to actually be discriminatory. When we look at inclusion, there's policy out there like Oklahoma, SB 1100, limiting the biological sex designation on the certificate of birth to male or female, prohibiting non-binary designation. So Minnesota, HF 3843, a person's sex is either male or female as biologically defined. And then when we look at things like social responsibility, right, that's one of the core values of our profession. There is policy that goes against that core value as well, like Arizona. SB 1138, irreversible gender reassignment surgery. So prohibits physicians from providing any irreversible gender reassignment to individuals under the age of 18, including all gender affirming surgeries. So things like phalloplasty and vaginoplasties. So, it's exhausting in some ways to think about all this policy and where do you start, right? Where do you start to fix that problem?
You brought up PT Proud, which I want to thank you for bringing that up. And I think it's a good place for us to pause here in the center. And a lot of people listening to this episode will be physical therapists or other health professionals. Tell us about the resources that we now have for physical therapists and others at our, at our national level that they can access to learn more about them. We're not done yet here today. We're going to go more into this topic, but let's just point them to some resources now they can start to educate themselves on early here. Well,
I mean, first and foremost, PT Proud has really grown in the last 3 or 4 years. We started out as a simple catalyst group in the Health Policy Administration, which is now the Academy of Leadership and Innovation. So that's great. Mm-hmm. But we have moved from a catalyst group to a committee. And we hope to, in the next year, move to a special interest group, which, Chris and I were talking earlier, and we really think that moving to a special interest group is going to give us some more leverage to kind of really start to stand up to the national organization or other organizations to make sure that we can advocate for these communities. But one of the most important things is for folks to understand how you can get involved, right? If you're interested in getting involved, we have multiple subcommittees within PT Proud. We have a membership committee, webinar, podcast, social media, advocacy, which has been very busy lately. So we can always use more help on the advocacy committee. But also to let you know that our website has also moved to the Academy of Leadership and Innovations homepage. So if you go to HPA The Catalyst and go under engagement, you can find PT Proud. And so we do have resources there. Chris worked really hard over the last couple of years, collaborating with OutCare so that we can add to our network of providers so people can find providers that are inclusive of our communities. Also, we have resources, educational resources. We do post all of our podcasts and our webinars also on the website. Mm. And we do have recommendations for different organizations that you can get additional information about our communities. Chris and Karla, do you all want to add some more to that?
I have a question for Chris specifically, because I know some of his work has been in this area. Chris, there are PT educators listening to this, and they're hearing you talk about those stats. Maybe there's 2 hours of this in the PT program, maybe. What would your advice be to educators who want to learn more about this topic and how they can start to insert it into the DPT curricula?
I think Karla and I agree on this, and Karla, feel free to chime in when I'm finished. But we both feel that the only way to make this really super successful is to immerse this in all PT content. So when you're presenting content on orthopedics, your cases are inclusive cases. When you're presenting content on inpatient acute care settings, maybe you are having cases of a patient that's had phalloplasty and you're mobilizing someone after phalloplasty. What does that look like? And wound care, right? Where we have patients that have had top surgery and we're talking about how to provide wound care to a graft site. How do we do wound massage on someone who's had top surgery and wants to reduce the, appearance of their incisions, and what's the evidence behind that? But if we don't start integrating that piece into all that we do, I feel as though we're doing our students a disservice, we're doing our community a disservice. And in addition to that, I think it's essential that those of us that are out licensed and practicing pursue continuing ed, right? Every year at CSM, we're providing brave space trainings. Most of us are doing our own educational sessions on these topics. And so continuing to pursue those types of education so that you can take them back to your home university and be able to provide that. But overall, it really needs to, in my opinion, come also from the administration at universities, where we're providing inclusive excellence trainings for all of our academics and looking at how to utilize pronouns. We know that affirming people's identities using pronouns having chosen name policies, gender inclusive bathrooms. There's so many things we can do in the academic setting to make that happen. In addition to that, on all of my syllabi, I taught this past year, I taught labs. So my students had to be in a special type, of attire where we could access body parts and whatnot, and making sure that that language is inclusive and respectful for anybody's identity, right? We oftentimes have gendered dress codes, having gender neutral dress codes on your syllabus, right? There's so many things that we could do. That's just like skimming the top of the iceberg there. But I'm going to leave it to Karla to kind of chime in here on if I missed anything that she's doing, because this is a big part of her research.
No, thanks, Chris. And absolutely yes to all of that. And to tag on what the research says about what we need in entry-level curricula, right? And so an entry-level health professional curriculum, not necessarily specific to physical therapy, but there's recent literature to suggest in the medical literature that these one-offs are actually maybe even worse than not doing it at all, but they're suggesting we need 35 hours or more of this specific content in our educational programs for our emerging professionals. And what that means is every faculty is responsible, right? And every faculty has to get involved, just like Chris said, threading through cases, threading through whatever. What that ultimately means is we have a faculty base that has no idea what they're doing in this realm, right? So professional development is really important. And there's not a lot of programs out there. I mean, I could speak to one of the research studies that I'm part of here at Thomas Jefferson University is a professional development program called Sexual and Gender Minority Education and Training. It is interdisciplinary, it is interprofessional, and it is a program that is aimed for faculty, staff, and clinicians alike. And so it is a comprehensive program that addresses cultural compatibility through the lens of knowledge being important for historical reasons of what's going on with these communities, and then all the way up to inclusive practices and practicing inclusive practices. And then action planning. You leave the program with a written action plan of what you are going to change in the next 6 months and what you teach or how you practice. And so those kind of programs are really important, because our faculty can't teach our students until they know what they're doing.
So that's your current work, Karla, as part of your PhD.
No, it's actually a research study aside from my PhD. My PhD work in my population health is actually, I'm going to be doing measurement development and creating a measurement tool to look at the likelihood of providers to use inclusive practices.
Chris, I know you just finished up your Ed D. Is that right, Chris? Why don't you give us a snapshot of what your research entailed with that? Because I think it was along the lines of a lot of what we're talking about today.
Yeah, that's correct, Joe. And so basically what I did was I took what I've been doing for like the last 8 years, kind of guest lecturing around the country at different universities, and took that, created a 2-hour module where I recorded myself doing an asynchronous type of instructional. And then I enrolled 130 participants that were already licensed clinicians. And then they had to go through the 2 hours. They took a pretest, which I used the Mark Biddell's LGBT Docs, which is a validated survey to look at cultural competency, right? And cultural competency, the way that we see it, is typically you acquire this group of this knowledge skill, and then you have this skill set, and you've kind of reached this start to a finish. And rather than like what Karla is talking about with compatibility, it's really about kind of pursuing this throughout our lives as clinicians and examining our own internal biases and what's going on for us and how we interact with our patients and how that impacts how we provide care. And so that's kind of the next step, is for me to go in that direction. But this was a very basic 2-hour asynchronous course, and it was pretty much everyone's scores improved. I had 30 clinicians that actually finished the study, and Again, part of that was a set of questionnaires that looked at whether or not individuals supported CAPTE accreditation, they supported this content being in academic programs in general, and then also whether there was going to be support for clinical practice guidelines. And that was pretty much unanimous across the board as well. So, it can be done, right? Even just in a 2-hour lecture course where you're just listening to the content, people's scores significantly increased on that study. And the people that actually finished had higher scores to begin with than those individuals that never engaged in the study course. Mm-hmm. So, overall, there's definitely an low-hanging fruit, so to speak, on this, because we come from a society where, and in a profession where there is very little training for folks in general. And so if we can create this type of content in a continuing ed way, a method, and in our classrooms, there's such a significant impact that we can make for our patients in particular and the type of quality care that we provide. So it really is low-hanging fruit, so to speak, because there just is such little on this. Hopefully, WPATH standards of care will be coming out soon. The new standards of care, which will help drive more content for the trans side of things that's evidence-based. That's really typically where most health professions get their trans-related content. They're pretty much the leader and of the standards there. So I'm looking forward to that coming out soon so that we have more driving that as well. So fingers crossed that, we can continue to make change and publish more research on this stuff. I mean, Mel, you should chime in here on all the stuff that we are doing with our studies, since you're the PI on that.
Sure. So lots of great stuff happening. We're right about to publication for our clinical phase of our study. It was a national multiple phase study using mixed methods, so qualitative and quantitative research methods. The clinician arm of the study was the first phase. We are complete. The writing is nearly complete, so we're hoping to present it to PTJ. So look out for that publication. But the second part of that publication was the quantitative part. So we took themes regarding barriers to LGBTQ cultural competence from a clinician perspective and created a cultural competency survey tool that is specific to physical therapy. We did do, really what we did was a pilot study. We had about 180 subjects that participated. We're going to publish it as a pilot, and we are collaborating with Heidi Janenga, who is the co-owner of WebPT, and we will be putting our survey out on a much larger platform to validate that survey. We are continuing to talk to faculty and students about their perceptions of the barriers to cultural competence for these communities. And we just started this spring into this summer talking to patients. So lots of great information to come out. I do want to mention that we're also, I'm also involved in some other work around gender affirmation surgery. We have a paper in process for publication right now with Transgender Health, looking at the implementation of pelvic floor physical therapy, the rehab for individuals that have had vaginoplasty. And we are working with the University of Colorado Health, Anschutz, and Denver Health right now, both of which have gender affirmation surgery programs. And I'm working with a pelvic health therapist, her name is Christina Holland, to develop another research project looking at the outcomes, status post-gender affirmation surgery after providing a pre-surgical educational sort of session for patients. So lots of research to come out. I will say that the multi-phase national study that we're doing is almost like a needs assessment to a much larger project that all of us are going to be involved in, which is developing standards and competencies that are specific to curriculum of DPT, and actually all rehab sciences programs. So we feel like it's really important to be inclusive of all rehab professions in that regard. So some great things happening, Joe.
The pelvic health therapists have been wonderful allies in all this, haven't they?
They sure have. And at this point in time, they are the most knowledgeable around our specific communities and the care that we provide.
Yeah, we want to thank them, of course. Who do we need to win over in our profession? Pelvic health is already there, right? They're seeing these populations in practice. They've been treating them for years and have even started to develop some of this in their practice. Who do we need to start to really educate more in our communities within the physical therapy profession?
I think the interesting part there is saying that the pelvic health therapists have been the ones that have been treating us. I think that everyone has been treating LGBTQ people, and that the issue is that we're not recognizing that those folks have specific needs that should be met in a different way than cisgender heterosexual people. And so I think that's the piece where, in order to win everyone over, so to speak, is we need to address all clinicians. Mm-hmm. We need to really get people to acknowledge this and really realize that you are engaging these people every day. You just don't know it because your environment is likely not inclusive, and we're not disclosing and outing ourselves because we don't feel safe to do so. And so with this current legislation that's happening right now with anti-trans athlete bills, anti-gender affirmation medicine, bills that are actually criminalizing parents that provide gender affirming care to their children, we're mandated reporters, right? So if you work in the state of Texas, the new law basically says that if your patient comes to you and they're a minor and they disclose that they're getting gender affirming care, you're a mandated reporter, because that is technically child abuse in Texas right now with the new policy that's been passed. Mm-hmm. So, recognizing that this is really happening across the country, that we exist in many different facets, and most of the time, unless we out ourselves, you don't know that we are part of this community. And so winning over everyone, from acute care to outpatient to inpatient rehab settings, this is something that impacts everyone's practice. This isn't something that you can pick and choose. It just so happens that, thank goodness for the pelvic floor folks, y'all have been driving the change and have really been saying, like, this community deserves recognition and deserves its own special set of quality practice. So thank you all for that. But this really is relevant to everyone. And I think that's the part that people in our clinical practice and our profession have not quite wrapped their heads around. And I think many of us, I see a lot of shaking heads here, have experienced that. This has been our experience, where our colleagues in academia, our colleagues in clinical practice don't acknowledge that we have a unique set of experiences that make us different from other people, that drive the quality of care that we could be potentially providing to our patients that part of this community.
And Chris, just to add quickly, you bring up some great points, and I would also add, semantics matter for a professional organization. And when we have DEI initiatives that are put on the very top of what we're supposed to be doing and supposedly implemented and prioritized now moving forward, but you are not inclusive with what you mean by diversity, equity, and inclusion, semantics matter. So, for example, when you are talking about diversity initiatives, DEI initiatives, but you are specifically talking about race and ethnicity, then say that. Don't say diversity, equity, and inclusion initiatives, because they really are not all inclusive, right? So we need to be specific about what we're addressing. And if we do that as professional organizations, what you will find is we are invisible in those initiatives. And that is also a priority that we need to address, because these communities and populations continuing to be invisible in health and the health needs that they have is a travesty.
And I think, just to round out the conversation, just to really, in our research, we do ask folks, How do we reach people? Where do we start? How do we make change in this area? And one of the most critical things or recommendations that we get is back to education, right? So it's got to start at the educational level. Our entry-level therapists need to go out prepared to treat these communities. And so can we make change for individuals that have been out for 30 years? Maybe, maybe not. But we can make change now, right? With the folks that are going out now. And hopefully that change will translate, right, over time. But that is really one of the most critical places that we need to start as a profession.
So we've talked about politics and policy. You've talked about competency standards within the profession. We pointed people to some resources where they can access within our profession specifically. There are going to be people who are listening to this, or maybe see this topic come up in other venues, other areas, and they might say, I was raised with good values, and I treat everyone the same, and I treat everyone like a really good person. And I don't really see why we need this, or why I need this, or why our profession needs this, or why we should put energy, resources, and money toward this. I'm wondering if the three of you, either individual or collectively, have a case study or a case example, without obviously mentioning names, of how that hasn't worked and how that's failed, like a particular individual, so to speak. Because really what we're talking about here is obviously validating people and their lived experience, but then how that translates to their care as a human being. And a lot of what we do as professionals is really build resilience in people. And I think when people approach it like, my parents raised me with really good values, I don't think they understand the resilience opportunity they have to work with this particular population to increase their resiliency even more, just by having an affirmative practice agenda in their practice or as part of their stance as a professional.
Joe, I actually have a direct case here that I can speak to from our research. I can't say a lot about it, but it's from our patient research. And we did have a younger individual that I'd say early 20s that identifies as non-binary. And so one of the things that we talked about in the research is, the fact of whether or not, or whether they know an institution or an organization or a clinic is inclusive of our communities. And this individual spoke of their experience and said basically that they went to a clinic that was recommended to them, and that they were excited because they felt like they were going to a clinic that was highly inclusive. The intake paperwork was inclusive of their gender and sexual identity, their preferred name, things like that, right? So at the intake portion of their session, they were very pleased with what looked like an inclusive climate. The problem happened when they went back and saw the physical therapist. So there was a breakdown. So this clinic is promoting itself to be an inclusive clinic, but then yet their providers don't have any knowledge of inclusive practice. And so for this individual, it became a challenge, right? Because now that role, so they were assuming that this individual is knowledgeable and that they knew of the mechanisms to treat them effectively, and they did not. So now the role reversal happens. And the question for this individual was, do I actually take the time to educate this person, which is exhausting and challenging? It makes me more vulnerable because I didn't think I would have to do that in this context, right? Or do I just let it go and not come back to this clinic ever again, which is sort of a travesty, right, in itself. So I think one of the problems, all these clinics, they want to become inclusive, which is really great, and they want to promote that climate, but we need to make sure that the clinics are prepared to actually treat this clientele as well. So that's just an example.
And I can speak a little bit to that question too. I mean, and putting out a shout out to your up and coming book, right? And lifestyle medicine and physical therapy, the chapter that we all contributed to gives some very illustrative points of, the impact on these communities of our behaviors and the inequities that exist, and facilitators and barriers, right? So there's a great table in that book as well. But I think of some literature out there, and there's not a lot, but when you look at Ross and Setchel's 2019 study, looking at the experiences of patients who are LGBTQ plus and what they highly recommend we do as a profession, that's a great article that talks to some of the experiences. But also Calzo, I think it's Calzo et al., put out an article on physical activity and the differences in sexual minority youth. And, our lane here, why we care as professionals and PTs, why should we care? Just look at the again, I'm going to go back to the legislation. What we are doing is a travesty to physical activity and gender minorities in this country, okay? We know all the goodness that goes along with promoting physical activity in sports. That is being taken away from these communities, okay, in some states. And Calzo et al.'s article specifically talks about the significant differences in moderate and vigorous physical activity with sexual minority youth versus non-sexual minority youth. And so we know, we would love to have more research to denote what some of these other things are, but people don't do this kind of research and we don't collect these demographics. So we have to go with what we have. And so there is some robust information out there in the little literature that we have that points to the fact that physical therapists have a main role in needing to know these communities and their health needs and to intervene and help provide the interventions from an educational perspective and a clinical perspective to help them promote their healthy lifestyles.
So we're going to start to wrap up, and I want to give you all an opportunity just to talk to your peers for a minute, because you're educators, you have peers on a university level, you're doing research. And what's the one thing you really want them to take away from just this conversation, from the work you're doing, and how you want their support in this important topic? And I guess we can go Chris, Karla, and then maybe Melissa.
I think, as we discussed a lot today, one of the biggest things is acknowledging that there is a problem. I think from what we've all seen, and that's part of the reason why there isn't a lot of research on this, because no one has seen it as something to investigate in the past. And so we need to acknowledge that there is a problem in our profession, that there are a unique set of needs and health disparities experienced by these populations that require us to change how we practice and how we teach and how we educate and how we move forward as a profession. And so the only way for that to happen is for us to gain more support across the organizations, the professional organizations of our profession. And the only way that that's going to happen is if people that don't look like us and talk like us start singing the same chant that we're singing. So that's my piece is, this is an important issue. It's happening. There's lots of research to suggest that there are significant experiences, whether they're driven politically or otherwise, that there is a serious problem here for the LGBTQ populations. Other professions have seen it. Other professions are singing the same chant we're singing. We need the rest of you to do the same.
Thank you for that, Chris. I echo every single thing that you just said. And, I would add, I'm begging people to understand the urgency of what's going on in our country for our populations right now. We are being erased at many levels, or trying to be erased. We will never be erased. Let me stipulate that. But I have to be honest. This starts with people who, again, don't look like us and identify like us, speaking up, because we as a community don't have the power, right? It comes back to power and privilege, and speaking your truth when you have that privilege. And we need people in our profession and in our educational programs and in our clinics to speak up and be public about the fact that inclusion of our populations in our profession is really important. And they need to understand why. So then they need to further their education, right? And our curriculum committees in our educational programs need to step up their game. They need to bring this conversation to the table. I can honestly say I'm still waiting for that to happen in many of the programs I know. And when it's brought up, it's immediately put under the table. And that's a travesty in itself too, because we can't continue to perpetuate this invisibility in our health profession.
Thanks, Chris and Karla, for both of your sentiments. And I agree with every last word that both of you have said. I think the way that I want to round out what you've said is just to really make a plea to our profession to keep an open mind, maintain that curiosity and that wonderment in your practice, in your educational practices. It's really important to be able to have sometimes difficult conversations and discussions. But if you keep an open mind, that helps to move the practice and research along. We don't want to halt right where we are now. We want to keep moving, and we need you to help with that. And what I would recommend is actually, there are individuals that have fear in some areas of the country to bring this content back. And what you could do is collaborate with somebody like us that is knowledgeable and bring us into your institution. Let us do the work for you. So collaboration is a big piece, and having an open mind to that possibility or opportunity is one of the first steps.
I want to thank Melissa, Karla, and Chris for joining me this week on this episode. It's an important episode that I always enjoy doing once a year. And even as I look at this, I'm like, why am I just doing this once a year? This really needs to be more than once a year. And I do it in others, probably smaller ways, but just speaking with you has helped me just reflect on what my behavior, what I'm doing. If I'm saying this is important, there needs to be more that I do as an individual than just in June for Gay Pride Week, so to speak, right? So I want to thank you for opening my eyes to this topic. As I see it, it's important for all of us individually and important for our profession. I'm going to include links to Melissa, Karla, and Chris's LinkedIn accounts. So if you want to reach out to them and learn more about the work they're doing or the educational resources they have on this topic, that'll be on the website at the Integrative Pain Science Institute.com. You can just go to that website and scroll over to podcasts and then scroll all the way down to the bottom and you'll find all their biographical information, their LinkedIn accounts, as well as other information about the great work they're doing. Of course, share this episode with your friends and families and colleagues who are interested in this topic, and those who maybe are not interested and we need to raise awareness around, share with them too. I'm Dr. Joe Tatta. Happy Pride, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.